everybody's aging,
Yeah.
You're not that young still. So she's up to her age. Yes, how all of you are, because I had been to Bhagalpur a long time back.
Yeah,
Still I remember
into
the
Bhagalpur.
hospitality that I received from there. And I still remember the Bhagalpur Pratibha Singh. Yeah.
Thank you so
I'm
much.
very happy that I could be able to talk to you even at this stage.
Yeah, definitely, sir. And it's really honor for us that you have joined with us. Thank you so much.
I'm very happy and very proud that I'm again talking back to you after, I think it is about 20 years ago.
Yes, 2007 you had come, sir. 2007.
Yeah.
Yeah, sir.
Yeah.
So we are starting now, sir. Okay, sir.
Yeah.
Okay.
Right, ma'am. Thank you. So good evening, doctors, and thank you for joining today's webinar. A warm welcome yet again for another knowledge update series. Today we are going to discuss IVF a step forward. And before we begin, we will play a short video on Shield Connect.
Now, first of all, I must apologize for my two deficiencies. It is because of age. I'm a bit short of hearing, but anyway, I can make it up. Okay. And not short of faculty and memory, but short of hearing. I think you will excuse me for that. But anyway, what I'll be seeking, I'll be very clear in my thoughts and vocals, so don't worry about that. Yes, should I start or you just introduce me and then I'll start?
Sir, we will introduce you, sir.
Yeah.
Sir, we'll do that, sir.
Huh?
So we will introduce you, sir. After that, we'll start, sir.
So thank you, Chitra. Social Connect is our digital platform. We have a lot of webinars, or all our webinars are available on this digital platform. There are many blogs available. And yes, we have created a web page for our very own Dr. Pratibha Singh. Ma'am is Vice President of Bhagalpur Obs and Gynecology Society and also coordinator and IAC Foxy. And of course, she is whole and soul about this KU series. So thank you, ma'am. So before we begin, yes, we have Dr. Priyanka Roy with us. Sir is National Coordinator and Perinatology Committee of Foxy, is Zone Coordinator and also Infertility and Endocrinology Committee of Foxy. We also have Dr. Diksha Goswami Sharma. Ma'am is Director of Pushpanjali IVF and trained in reproductive medicine. Ma'am has various publications and also editor Foxy Focus on Infertility 2018. And Ma'am has special interest in PCOS and reproductive endocrinology. So with this, I will hand over the sessions to the doctors for further proceedings. Thank you.
Thank you, Team Shield. Thank you for giving us this opportunity today to have another episode of this knowledge update series. So we are having another excellent program as we have had in the past as well. Wonderful programs organized by Pratibha ma'am, wonderful faculties, and excellent knowledge sharing that has happened over the past few months as well. So before we start this program, I would first of all like to invite Dr. Pratibha Singh ma'am. Can I have the CV slide, please? Yeah, ma'am is a consultant laparoscopic gynecologist and IRT specialist in Bhagalpur. She is the director of the Healing Touch Multispeciality Hospital. She has been a past state honorary general secretary of the Association of Gynecologist Societies of Bihar and Jharkhand and founder secretary of Society of Vaginal Surgeons of India and Jharkhand chapter. She has also been the founder secretary of the Bhagalpur Menopause Society and vice president of the number of societies. She is excellently conducting this KU series, updating knowledge to all of us around the country. So I welcome ma'am over here to this platform, to her own platform rather, to deliver the welcome address and welcome our delegates as well as our faculty.
Thank you, Dr. Priyankur. And can I share my screen?
Yes, ma'am. Yes, ma'am.
Can you see my screen? Yeah.
Yes, ma'am.
So before I start, I just want to pray to God that soon we should come out from this dreaded pandemic and again our life normalizes. And it is said that after a dark night, there is a beautiful morning. So till then, stay safe and healthy. So good evening to all of you. And it gives me immense pleasure to welcome all of you once again to this Knowledge Update Series Part 2. And we are really overwhelmed by the amazing response we got from our viewers in our previous webinars. And I'm happy that you all liked the concept of this Knowledge Update Series and gained something out of it. So today, first of all, I would like to recollect and remind you all about this knowledge update series, which we had a fascinating journey of this first KU web series. And we had come up with 5 webinars in that series where our chief guest, guest of honor, special guest were all prominent personalities, present, past, and incoming president, vice president, and other office bearers of Foxy, which gave new dimension to this program. And our guest speakers were again authority in their respective fields, which included Dr. Osama Shauki from Egypt. He was master in hysteroscopy. Dr. Sailesh Putambekar, who had created history by doing successful uterine transplant in India. And Dr. Duru Shah, an authority in PCOS. Dr. Naren Malhotra, who is making all efforts to promote and introducing this aesthetic gynecology in our gynec world. And Dr. P. Das Mahapatra, again a legend himself in managing endometriosis. And all talks were quite informative and updated. And we had quite accomplished chairpersons and judges, which made this whole program so interesting and interactive. Then debates by our young and upcoming gynecologists were again quite interesting and thought-provoking. And finally, the quiz, Know the Legend, became very popular, where first 3 fastest fingers were presented with test book of different topics of ops and gynae. And as we were overflooded by the entries, so we decided to felicitate few more with certificate of appreciation. So I want to thank you all for appreciating this concept. And again, I would like to welcome all of you to participate in our next set of KU web series. And today we have come up with again a very important and interesting topic, which is a need of an hour, and that is IVF, a step forward. So we are truly blessed to have you all as a legendary in this field of IVF today. And let me welcome our chief guest, again an authority in IVF, past President Foxy, a very charming personality, Dr. Kamini Rao ma'am. Her presence has made this webinar exceptionally important and admirable. So welcome ma'am to this platform.
Thank you.
Our guest of honor is again a very popular Foxian, a renowned gynecologist, and at present she is the chairperson of Foxy ICOG, Dr. Mandakini Meghman. So welcome, ma'am. A very sweet personality with such a helping attitude that I have developed instant liking for her. And she's always there whenever we need her. So welcome to this forum, madam.
Thank you.
Now, our guest speaker is again a well-known IVF specialist from Indore, also a vice president-elect Foxy 2022, and her smiling face makes everything bright and happy. So welcome Dr. Asha Bakshi ma'am to this KU.
Thank you. Thank you, Pratibha. So sweet.
Most respectfully and humbly, I want to welcome our most awaited guest speaker, Dr. B.N. Chakravarti sir, who has inspired me to and developed interest in IVF. My first ART training was under his guidance in IRM, where I had spent almost 8 to 10 months and took training in IVF. And he is my first guru to shape my career as an infertility specialist. And I was also blessed by when he came to Bhagalpur and inaugurated my IVF center way back in 2007. And today I'm really happy and feel honored to have you here, sir. And I'm really grateful to you for accepting my invitation. And I will always cherish this moment. Welcome, sir, to this platform once again. I also want to welcome our chairpersons and judges who have joined from far and wide. Dr. Bhaskar Pal from Kolkata, Dr. Krishna Surendran from Nagarkoil, Dr. Parikshit Tang from Mumbai, and Dr. Radha Madhvi from Tiruvannamalai. Our debaters are again the promising IVF specialists. So I would like to welcome Dr. Aradhna Gupta from Bhopal, Dr. Rohan Palshetkar from Mumbai. And we are really looking forward for an exciting debate today. Last but not the least, I would like to welcome our convener, Dr. Priyankur Roy, who is always there for us, a very committed person. And along with him today, I want to welcome another convener, Dr. Diksha Goswami from Agra. And now I hand over the session to them for further proceedings. Once again, welcome to this platform and thank you so much. Over to Priyankur.
Yeah, thank you so very much, ma'am. Now we have, as ma'am has already mentioned, the exciting quiz that we have on our various on all the program days that we hold this program. So on 18th of March, we ended with a surprise quiz. The question of which was, which of the following is considered as a risk factor for development of endometriosis? Delayed childbearing, of course, was one of the factors, one of the answers that we had considered. And of course, correct answers were received within fraction of seconds. And I'm very happy to congratulate the winner of the fastest answer giver over here, Dr. Deepta Kanta Bora from Tejpur in Assam. So she wins a book on Stop Endometriosis and Pelvic Pain by Andrew S. Cook, and also a certificate signed by the guest speaker on that day, Dr. P. Das Mahapatra sir. So congratulations, Dr. Deepta, on your feat. I would also like to bestow the appreciation certificates on 5 other people who had given the answers very quickly, and they are Dr. Sunila Naidu from Visakhapatnam, Dr. Selvaraj from Tirupur, Dr. Nagaratnamma from Bangalore, as well as Dr. Kalyani Boini from Hyderabad. So congratulations to all of you. This fast answers makes us also very interested and makes us keep this quiz competition going on and on, because we know the interest that it has created among our participants. So thank you so much. So now it gives me immense pleasure to welcome our chief guest of today's evening, none other than Dr. Kamini Rao ma'am, a doyen in the field of infertility, as we all know. She is the director of Milan, the Fertility Center, which has a number of centers across India. She has been awarded the prestigious Padma Shri Award by the President of India in 2014. She has also received the Karnataka State Award, the Rajyastava Award for invaluable service in the field of medicine in 1997, and also the honorary PhD award. She has a number of publications in various journals, national and international, of course, 50 plus journals to her credit. She is also the past president of Foxy, past president of ISAR, and of a number of organizations as well. So it gives me immense pleasure to welcome ma'am to this platform and request a few words of blessings from ma'am.
Priyankur, I must say that it's always a pleasure on a gloomy day like this, sitting in a lockdown. But to say that we've had a little bit of an appetizer talking to all my colleagues, meeting everyone, greeting everyone, and knowing that the academics will not stop because of COVID. And that is something which gladdens my heart because we are still learning, even though we are in a lockdown, and doctors are always up and working. And this is something which we always look forward to, and I'm sure the politicians will also realize. The knowledge update series is a very catchy phrase, and also the fact that you have debates and quizzes, etc. These sort of interactive sessions is extremely important to ignite the young minds to come forward, because gone are the days when you had a whole lot of essay questions, where you could write anything and everything, and then you'd get marks for this. But to have a quiz and debate, as well as to have MCQs, and to be able to gift them with something or the other, like books, which is so important, it gives them that kind of satisfaction that their talent has been recognized. And you see that these will be the future Foxy presidents, perhaps PICO presidents in the making. And this is what I would like to congratulate, because the amount of uh, webinars I have seen in the last year and now is much more than we would have ever seen in the last decade. And I must say that it has gladdened my heart to know, to great extent, to see our founder, Dr. B.N. Chakravarti, here before me. Is actually a real blessing, because however much we talk about IVF, a word of praise for Dr. B.N. Chakravarti at this age to be interested to come and participate and to be able to guide youngsters is commendable. And to you, sir, my pranams and also my good wishes for your good health. And we'd like you to cross beyond that century and keep blessing all of us. I've always admired your work and your research and your tremendous energy. And with this, of course, Pratibha Singh, I must tell you that you're going great guns, and I want to wish you and also Mandakini Meg, because I've known her for a long time, and of course, meeting Bhaskar Pal as well. I think all of you are doing a great job. Keep it up, keep going. We're all there to back you. Thank you very much.
Thank you so very much, ma'am, for such wonderful words. Means a lot to us, especially, of course, during this COVID days. So thank you so very much, ma'am, for that. Now it gives me.
First session.
Yes, ma'am, I will request you to kindly stay back for some more time, ma'am. We have the quiz and we have the results, and felicitation from you would mean a lot to us juniors, ma'am. So I will request you to stay on for some more time. So now I would like to invite our guest of honor for today's evening, none other than Dr. Mandakini Meg, ma'am. Ma'am has recently, she was not well and she has come out of it, and she has come out full guns with full lot of energy, and is seen, and she is there in most of the webinars now, even organizing webinars, organizing ICOG certificate courses. And we all know her as the chairperson of the ICOG, doing wonderful work, doing work with organizing so many certification courses. And there's one certification course of PCOS which is also going on. So it gives me immense pleasure to welcome ma'am to this platform. She is also the International Vice President of the MWIA Central Asia, Vice President of the AMWI, National Vice President of Foxy in 2012-13, past President of the Indian Federation of Ultrasound in Medicine and Biology, past Dean of Indian College of Medical Ultrasound, and a number of accolades, number of positions that she has held in the past. So I welcome ma'am to this platform, and I request a few words from you, ma'am.
Yeah. So Priyankur, thank you. You brighten up my evenings, and Kamini, such a nice pleasure to see you always, and all the smiling faces. My dear friends, very warm good evening from Mumbai. And most importantly, I want to wish B.N. Chakravarti sir a very happy and long life. Kamini has said everything. but I really respect you, sir. And I just want to mention that you and me stayed at Dr. Rangila Sinha's, house in that night of, one of the program was there. CME was there, and me and sir was there as a host. And I remember that morning tea, relaxed atmosphere, big flowers in her, and I can't forget that. That doesn't go out of my mind. And BN Chakravarti's, sirs, the advice to the junior is still ringing in my voice, sir. So thank you for that lovely stay at Rangila Sinas and making all junior like us to do so much good in the in the life. So sir, thank you. And I acknowledge the presence of Krishna, uh, Pratibha doing a great job, Bhaskar, Asha. And I want to tell you that on other side, we are running the reproductive medicine courses. Everybody is mentioned. So there Nandita was talking about the, infertility updated. It was going on, and then from there I came. There also we are doing a lot of work in the reproductive medicine, and we are running the courses of ICOG for 3 months, and all these faculties there for our students. So this knowledge Pratibha, great job. And I'm all for the education and improving the education, and more knowledge is coming and making it interesting by quizzes, by everything updated, and more, having at ICOT that we are keeping the juniors hooked in this, challenging time, and we are turning these challenges into the opportunities. So I think the same is being done here, and I can see the renowned faculty here that they all everybody will be benefited, and keep it up. I think you're doing a great job. And also whenever you give us a ICOG call, I think in the middle of the night also we give the ICOG credit point, because people are doing a tremendous job, and thank you very much for involving us all the time. And I think knowledge sharing is the greatest thing which a human being can do in this world. So I think I wish everybody a great success. Stay healthy, stay happy, and remain negative and be positive. So thank you very much.
Thank you, madam.
A very important statement by ma'am. For this year, the best thing being positive is to stay negative. So thank you, Mandakini ma'am, for joining us and for your enlightening words. Next, I would like to welcome our special guest today evening, Dr. Asha Bakshi ma'am. Ma'am is ever smiling, ever encouraging, and always there for us juniors as well. She is the Vice President-elect of FOXY 2022, Joint Secretary of ISAR 2020-21, and a Managing Executive Committee of AICC RCOG West Zone, Founder Chairperson of the MP-IAG as well as MP ISAR. So it gives me, and of course, the Organizing Chairperson of the AICOG 2022 in Indore, which we are really looking forward to. So I welcome ma'am to this platform and request a few words from her.
Thank you, Priyankur, for such kind words. And you are really always very modest and nice. Thank you. Thank you, Dr. Pratibha. And it's really an honor to see this, to be a part of this program, Update Knowledge Series. And I think it is an excellent idea. And I'm sure that today, from the doyen of infertility, Professor B.N. Chakravarti, we are going to have lots of learning points in PCO. It is so nice to have Madam Kamini Rao and Madam Mandakini Megh here, and to see Dr. Bhaskar Pal, and to hopefully Dr. Parikshit will join soon. So it's really nice to, and Krishna, beautiful Krishna as well. So thank you so much for giving me this opportunity. And I'm sure we are going to have a nice debate and nice fight between Aradhna and Rohan. That would be again very interesting. So this program is going to be really full of, I mean to say action, not only just knowledge, but action also. So I think I'll not keep you all waiting from the main program, and let's just get going. Thank you.
Thank you, madam.
Thank you so very, so very much, Asha ma'am. Thank you so much for your words. So now we come to the results of our Know the Legend quiz. The quiz that got 109 answers within a matter of minutes, and surprisingly, most of the answers were correct. There were 90 answers which were correct, and there were a few answers which were very surprising. And some of the answers mentioned actually Dr. B.N. Chakravarti sir also. And we all know that B.N. Chakravarti sir and Dr. Subhash Mukhopadhyay sir were contemporaries and they have worked together. So we had those answers as well. So Dr. Subhash, actually, frankly speaking, this is the first time that I personally could get a Know Your Legend answer correct. Previously, I knew none of them. But this time it was Dr. Subhash Mukhopadhyay sir from Kolkata. He was a little bit of a personal touch. Actually, he was the superintendent of the hostel in which my father was there when he was doing his post-graduation. And so my father does talk a lot about Dr. Subhash Mukhopadhyay sir. So yeah, of course, the answer was Dr. Subhash Mukhopadhyay. Now let's come to the prize winners. Congratulations to all the winners. First of all, I would like to congratulate the first prize winner. And let me tell all of you that the winners of all the prizes gets books from Dr. Kamini Rao ma'am's books. So the first prize goes to Dr. Sidra from Mumbai. Congratulations, Dr. Sidra. She's there with us today as well. She'll be giving a short note on Dr. Subhash Mukhopadhyay, telling us about his life and details about him. So congratulations, Dr. Sidra, on winning the prize, and you get the infertility manual, a very nice book by Dr. Kamini Rao ma'am. So the second prize winner is Dr. Shushma Bakshi from Baroda. So Dr. Shushma wins another book from Dr. Kamini Rao ma'am on gynecological emergencies. So, so congratulations, Dr. Shushma. The third prize winner is, it was a tie between Dr. Sonal Dubey from Raipur and Dr. Samuel Seth sir from Kolkata. So even seniors like Dr. Samuel Seth has also participated. That gives us a lot of enthusiasm as well. And the third prize is a split between two of them, and both of them will get Handbook of Gynecological Emergencies by Dr. Kamini Rao ma'am. So I would request Dr. Kamini ma'am to kindly felicitate that before we move on to the next prize winners.
Of course, it gives me great pleasure. And of course, it's a big surprise that you've chosen this book. And I feel much, happy that we're now looking towards Indian authors rather than only looking at foreign books, because looking at the Indian patients is totally different what they would see abroad. And I'm glad to say that this book, Gynecological Emergencies as well as the Infertility Manual, has been extremely popular. And I would love to see that it is there in every gynecologist's, the thing table. And I hope they read it. But more importantly, the fact that you brought this out with a debate and fastest finger first and Know Your Legends, I think there's a little bit of a fizz in everything. And I like it very much. I really like it very much. And this reminds me of a day when they did have this in Foxy. And I remember Dr. Shirish Tafri putting in that quiz of who is the youngest Foxy president, and people are still struggling. And my name came up and I was quite shocked. So when you talked about Know Your Legends, this suddenly came to my mind. So I am very, very happy, Jankur, and I'm very happy for all the winners. And I wish them all the best. And I hope you accumulate more books. But more importantly, please read the books and don't just accumulate the books. Thank you very much, Priyanka, and all the winners. Thank you very much.
Thank you, madam. Thank you so much for joining.
Thank you, Kamini ma'am, for being here today evening. Thank you so much, ma'am. So next, we would like to felicitate the fastest finger first, the people who have answered first. We are giving 10 appreciation certificates to them, and Mandakini ma'am will felicitate them at the end of announcing the winners. So the winners for this appreciation prize are Dr. Neha Priyadarshini from Dhanbad. Congratulations, Dr. Neha. Next, we have Dr. Bindu Arya from Patna. Congratulations, Dr. Bindu. Dr. Shilpa Sakure from Raipur. Congratulations. Dr. Priyanka Shahi from Chhapra. Dr. Rajasi Sengupta from Nagpur. Congratulations, ma'am. Dr. Charmila Ayavu from Trichy. Dr. Mahadev Ram Tondare from Virat. Dr. Ashana Kumari from Bad. And Dr. Anita Vima to the winners, and Mandakini ma'am, a few words of felicitation that will encourage them.
So thank you very much, Priyanka, once again. And to give even the smallest appreciation is a great boost to the person. I can see from junior to Charmila to senior, and even I saw the MTP chairperson. So exciting for everybody. So great congratulations to all the winners. And I can't spell their name, but I am giving them the certificate of appreciation. And I think, what are you giving? Priyankur, I lost that. What are
Ma'am,
we giving?
certificates, ma'am,
Certificate of
certificates
appreciation.
to all the doctor, ma'am.
And Kamini, your books are so popular that in our, reproductive medicine series also we keep on mentioning that please read this book. So I think, that's a great gesture to give. And I think I congratulate everyone and keep it doing. And this only gives an interesting mix of senior, junior, and everybody who, and in this challenging time, I think we need more and more of it. So I think, great, thank you. And congratulations again to the winner. And please keep your program going. Thank you very much.
Thank you, Mandakini ma'am. Thank you for, I'm very sure our winners will be very happy with your felicitation. Thank you, ma'am. So next we have 6 more awards. These are called the consolation certificates. These certificates are for people who have answered all the past quizzes that we have had, answered most of them correctly. So we have a lot of seniors in this category this time. So congratulations to the winners. Our first winner is Dr. Banita Sahai ma'am from Jamshedpur. Congratulations, ma'am. Next, Dr. Sneha Bhuyar ma'am, our breast committee chairperson from Yavatmal. So congratulations, Sneha ma'am, for your certificate. Then we have Dr. Archana Jha ma'am from Bhagalpur. Congratulations, Dr. Archana. Dr. Alka Godbole ma'am from Thane. Congratulations, Dr. Alka ma'am. Dr. Sangeeta Pama ma'am from Amritsar. Welcome, ma'am. And of course, Dr. Prerna Agarwal ma'am, from Firozabad, the president of the society. So congratulations, Prerna ma'am, for your certificate as well. So now I would invite Dr. Asha ma'am to kindly felicitate the certificate winners, please.
Heartiest congratulations to the winners. And quiz is really a very good idea. It really tantalizes your brain, and learning becomes very interesting. And I can see here right from juniors to seniors have participated, and it is participating which is very important, whether you win or not win. But if you are participating, that also gets your endorphins in the circulation. So I think it's very, very important, and heartiest congratulations to all of you, and keep it up.
Thank you, madam. Thank you.
Thank you so very much, ma'am. Now we'll have a short talk by Dr. Sidra from Mumbai, who has won the Know the Legend quiz on Dr. Subhash Mukhopadhyay. So I would request Dr. Sidra to kindly share your slides, and you can please go ahead and talk about Dr. Subhash Mukhopadhyay. And thank you, Asha ma'am, for being here and for the felicitation. Thank you, ma'am. Dr. Sidra, yeah.
Yeah.
Yeah, so let me just introduce you shortly. She is a fertility consultant at the Aishwarya Fertility Center in Thane. She has done a fellowship in reproductive medicine and presented a number of papers, and also is a member of FOXI as well as IAG. Welcome, Dr. Sidra, and over to you.
Good evening to all colleagues and esteemed faculty. It's quite an honor to be over here and talk about the legend who made India proud in that field of medicine, which is really close to my heart, infertility. And I would really like to thank Dr. Pratibha Singh for giving me this glorious opportunity. 25th July 1978, the world welcomed its first test tube baby, Louis Brown, who was brought into existence by the efforts of Dr. Robert Edwards and Dr. Patrick Steptoe. Little did we know that the good news of world's second test tube baby birth was baking in our own oven. And the genius who made this possible was none other than Dr. Subhash Mukhopadhyay. Let's get to know this legend and the groundbreaking techniques developed by him. Born on 16th of January in the year 1931 in Hazaribagh, part of present-day Jharkhand, Dr. Subhash Mukhopadhyay was the cutest kid since his childhood. After completing his BSc in physiology, he went on to do his MBBS from Calcutta National National Medical College, where many of his colleagues observed his keen interest in innovative gynecological techniques. This made him pursue PhD in reproductive physiology from Rajabazar Science College. In the year 1957, he earned his second PhD in reproductive endocrinology, after which he took up the post of lecturer, professor, and reader in physiology at Neel Ratan Sarkar Medical College, Kolkata, where he started laying the path to new avenues in the field of reproductive medicine. Dr. Mukhopadhyay started his novel research on ovulation and spermatogenesis in his very personal lab at his residence in Kolkata, with a team comprising of Mr. Sunil Mukherjee, a cryobiologist, and Dr. Saroj Bhattacharya, a gynecologist. The zeal of the genius was met by the need of a worn-out couple, Mr. Prabhat Agarwal and his wife. The poor couple had been humiliated and called derogatory names by the society due to the inability to bear a child. The pain was so extreme that they were willing to take up a treatment protocol which was in experimental stages. Within a year, fruits of this bravery ripened. On 3rd of October 1978, Durga was born. This incident happened precisely 67 days after the birth of the first IVF baby in the world. But the same happened with Dr. Subhash, which happens with every person who does something new. He announced in the press the birth of Durga, but his claims were obscured with controversy. The political, medical, and administrative system of West Bengal demotivated him. The government formed an inquiry committee to investigate his work. But sadly, this committee was formed of members who had little to no knowledge of advances in modern reproductive techniques. The committee didn't comprehend his work, and hence they gave a verdict that his research was fake, and which started a vicious cycle of ridicule. Also, he was transferred to the Department of Ophthalmology so that he could not further continue his research. He was denied permission to travel to Tokyo in November 1978, where he was invited to speak about his work. And had that happened, the world would have known who this genius was. Frustrated by this mockery and accompanied by his deteriorating health, Dr. Subhash Mukhopadhyay committed suicide on June 19, 1981. His death note read, "I can't wait every day for a heart attack to kill me." That's actually very sad. 9 years later, on 6th August 1987, the first documented IVF child of India, Harsha Chavda, took birth with the joint endeavors of Dr. T.C. Anand Kumar, a reproductive biologist, and Dr. Indira Hinduja, a gynecologist. On his visit to Kolkata for the National Science Congress, Dr. Anand was handed over by Dr. Sunil Mukherjee the handwritten notes and research papers of Dr. Mukhopadhyay. Until then, Dr. Kumar was unaware of the existence of Durga. After studying these notes, Dr. Kumar came to the conclusion that Dr. Mukhopadhyay was a true pioneer of IVF in India. And not only that, the techniques which was used by him was way superior to the one used by Dr. Robert Edwards. How so? Let's have a look. Dr. Robert Edwards used natural cycle IVF. But Dr. Mukhopadhyay did ovarian stimulation, and he used HMG. Yes, our favorite HMG. And he thought of using this when nobody in the world had even thought about it. And he made this hormone in his own lab. On the other hand, let's come to the next one. Dr. Robert did ovum pickup by laparoscopy. On the other hand, Dr. Mukhopadhyay did ovum pickup by posterior colpotomy, a procedure which is taught to every student in their residency. And it doesn't even require any expensive equipment. A way better option during the pre-ultrasound era, I should say that. Dr. Robert did fresh embryo transfer. On the other hand, Dr. Mukhopadhyay, in his initial stages, went forward with frozen embryo transfer. He froze an 8-cell embryo and thawed it and transferred it in the next cycle. And we all know freeze-all is the thing which has gained immense acceptability in the current time period. Dr. Kumar delivered Subhash Mukhopadhyay Memorial Oration in the 3rd National Congress on Assisted Reproductive Technology and Advances in Infertility Management in Kolkata in February, and published an article under the title Architect of India's First Test Tube Baby, Dr. Subhash Mukhopadhyay. He persuaded ICRM to honor Dr. Dr. Subhash Mukhopadhyay with the recognition which was long deserved. Dr. Kumar also helped Durga come out of the shadow in which she hid due to the social pressure. 3rd October 2003, Durga attended the ceremony organized in the memory of Dr. Mukhopadhyay, where she publicly revealed her true identity of being Kanupriya Agarwal, daughter of Prabhat Agarwal, the miracle child born by the efforts of this legend. She expressed her happiness. Dr. Mukhopadhyay's hard work has finally seen daylight, received the acceptance which was long due, and was featured in the Dictionary of Medical Biography, which is published by the World Foundation. Thank you.
Thank you, Dr. Sidra. That was indeed a wonderful presentation. And we all had the privilege of meeting Ms. Anupriya Agarwal, rather Mrs. Anupriya Agarwal Durga, in the last ISAR in 2020 in Hyderabad, probably the last physical conference that we all attended. So thank you, Dr. Sidra, for your wonderful presentation.
You're welcome.
Thank you for that.
Thank you for giving me this opportunity.
Congratulations, Dr. Sidra, for winning first prize.
Thank you so much, ma'am.
So now we move on to the guest lecture. Can I have the CV slides, please? I would like to welcome the chairpersons for this session, Dr. Bhaskar Pal sir. We call Dada, our elder brother here in West Bengal. He is currently the president of the prestigious Bengal OBGYN Society, chair of the AICC RCOG, vice president of the IAGE, where he will soon take over as the president, Foxy representative to SAFOG from 2021 to 23, as well as the chair of the organizing committee of AICOG 2022, the AICOG after Indore, which we also, of course, look ahead to. So welcome Dr. Bhaskar Pal to this platform. And with him, we have Dr. Krishna Surendran ma'am. Ma'am is a consultant at the Gopala Pillai Hospital in Nagarkoil. She was the secretary of the Nagarkoil OBGYN Society, has served also as the joint secretary of the IMA Nagarkoil branch, and recently has taken over as the president of the Nagarkoil OBGYN Society. She has won a number of awards and also has published a number of papers in various journals. So welcome, ma'am, to this platform. Now I would request Dr. Bhaskar Pal to introduce our guest speaker, Dr. B.N. Chakravarti, sir. And I would just like to mention a line over here that my personal touch with B.N. Chakravarti sir started from the day I was born, because my cesarean was done by him and my father was a student of Dr. B.N. Chakravarti sir. So welcome, sir, to this platform, and I request now Bhaskar sir to kindly introduce him, and after that we'll go ahead with the topic.
It is really an thank you, Dr. Pratibha Singh and Priyankur, for inviting me, and it is really an honor to introduce sir, who everybody knows, but even then we'll have to do the formal introduction. I think what is not written on the slide is sir is the teacher of teachers, not only in obstetrics and gynecology, but also in the field of IVF. So many people have got trained in sir's institute and then gone on to set up their own centers and become very famous. And sir has been one of the pioneers of IVF in India. My first interaction with sir will not remember when I was a medical MBBS student at medical college, and at that point of time the scientific program of medical college reunion was well attended, and 1 hour was always left for gynecology, and sir came and gave a lecture of 20 minutes on PID, and I never thought that PID could be made so interesting. It is always a pleasure to hear sir, and his amazing knowledge and his zeal for education even at this age keeps inspiring us. Sir is the director of the Institute of Reproductive Medicine in Kolkata. He is the ex-chairman of the ICMR Committee for formulating of national guidelines for regulation, supervision, and accreditation of ART centers in India. He was the convener of the postdoctoral fellowship course in reproductive medicine under the National Board, Ministry of Health and Family Welfare. Sir has been a past visiting professor at Wadia Maternity Hospital, Mumbai, Maternity and Child Hospital in Riyadh, Saudi Arabia, PGI Chandigarh, and Jipmar and Pondicherry. Apart from being a practitioner, sir has been a wonderful research mind, a phenomenal scientist. He's had research collaboration with IIT Kharagpur, CISR, in Indian Institute of Chemical Biology and Bose Institute in Kolkata. He's received a number of awards, 26 to be precise, including Lifetime Achievement Awards. The total number of chapters that he's contributed in national and international textbooks is 34. He has total 100 publications in peer-reviewed international journals. He's edited 5 textbooks, and his research interests include endometrial receptivity, luteal phase support, and recurrent miscarriage. And he's been an honorary member of the International Federation of Fertility Societies, which was conferred to him in September 2016. Sir, we are all eager to hear from you.
In the beginning, I must appreciate Dr. Pratibha, not really appreciate, but thank Dr. Pratibha for remembering me after 20 years and invite me to this August meeting, which is so important from one personal point of view that I was associated with the story that has been said about Subhash Mukherjee.
Thank you, sir.
But it is a pity that my name has not been mentioned, although I was all along associated with Dr. Mukherjee and Dr. Mukherjee's effort. A little bit before PCO, and how was this association? It was a miraculous thing. I was posted as assistant professor of obstetrics and gynecology at NRS Medical College, and Subhash was posted as assistant professor of physiology in the same medical college. We had a common interest of uncommon topics of unknown etiology and univocal or not predictable outcome. And I was interested with histroplasty, vaginoplasty. I was interested with no predictable outcome. I was interested in tuboplasty at that time, 1965. I'm talking a story of 1965 when we came both together. And he had interest in all those endocrinopathy, that is the CAH, that is the congenital adrenal hyperplasia, testicular feminizing syndrome, and all those primary amenorrhea, all those. So we had a liking for each other. And that was the area where we joined together. And he used to help me in my cervical technology by giving a theoretical support. And I used to help him in his objective of designing a diagnosis and outline of treatment in these unpredictable topics in which he was interested. Anyway, we joined together and worked in a CIT road in NRS Medical College. We used to publish papers, and therefore we were transferred, he to Bankura and me to Siliguri. But anyway, we still kept our touch connection together. And at that time, I used to see that he used to bring these hormones. And at that time, gonadotropin were not very much known. And Antex and Pysex were the HMG and HCG used in those days. Animal gonadotropin. And he used to inject this animal gonadotropin into agiospermic husband. We used to have, what used to happen, I did not know, but he used to bring this and through some medical representative, and he used to inject in agiospermic. Anyway, our relationship grew on, and then ultimately he declared that we just collected many names where it was irreversible infertility, where we said when you come back to Calcutta, we'll start an IVF unit and we'll do this. That was 1967, 68. But anyway, in between, what did happen, you have heard that while we were in Bankura, he declared that a testy baby was born, her name was Durga, on 3rd of October, 1978, the same year in which the Oldham baby was also born. Anyway, that was the beginning. And then end came like that. And after we started also in unit, but did not could produce a baby. But after Subhash's death, when people did not believe him, and he did so many miracles, which I knew, and I thought that I must go ahead and prove that he was not a liar. Because he was proved to be a liar, and the government was after him, and the way in which he was victimized on open platform, in open newspaper, that he could not tolerate the insult, and therefore he committed suicide. And even when I was not also spared because I was with him, and I just went to deliver a lecture at some other places inside India. Oh, he's a Bengali. He does not speak his truth. And when I used to Australia and just delivered a lecture on histoplasty, vaginoplasty, I heard the people were very appreciative. They clapped, but in modesty, and say he's coming from India. So these are the remarks that I heard myself. And therefore, I felt also very much insulted and took a challenge. No, I will show that India also can do something which cannot be disbelieved. And that's the reason why I started that. But anyway, that's the initial story which I had an idea about Subhash Mukherjee. Now we come to our own subject, there's the PCOS and infertility. And this subject I had taken in because this is a very, very common topic that everybody sees, not only in infertility practice, but in gynecological practice. And when I start with, I'll talk in my own way. This is one of the commonest female endocrinopathies, commonest causes of anovulatory infertility. And there are three different problems in three different decades of a woman's life. In the adolescence, the commonest problem are menstrual and cosmetic problems. And these are the problems which a girl comes at the age of 14 or 15 with PCO, commonest disease of the adolescents nowadays. In the childbearing age, infertility and miscarriage, and the perimenopausal age, diabetes, hypertension, carcinoma of the breast, carcinoma of the uterus, and coronary arterial disease. So these are the common problems of all the decades of a woman's life. So PCO is a common, and PCO will remain evergreen in two areas. Number one, etiology. Well, etiology is not well clear still now, and and I'll come to that later on. Now, what are the contents of this talk? A clinico-pathological mystery, and the changing concept. It was initially believed to be a gynecological curiosity, but now it has come down after the introduction of RIA, after the introduction of ultrasound and the multiple imaging system. It has come as a multiple system endocrinopathy. The presumptive etiological background I touched to some extent. The clinical presentation of PCOS women. I mean, all PCOS are not similar. I have graded them into three groups, to grade A, grade B, grade C. And according to the severity of the grading or the presenting symptom or the presenting signs, we have to modify or we have to change our treatment protocol as well. And the practical management, which we do at IRM Kolkata. Now, historical landmark. In 1721, young married peasant woman, moderately obese and infertile, with two larger than normal ovaries, bumpy, shiny, and whitish, just like pigeon's egg. A case report was reported from Italian physician. Then the record comes to 1900, after 1721. There's such a long gap, described as the sclerocystic changes in the ovary, and from where the name polycystic ovary has come. 1935, the actual description of the polycystic ovary was brought in by Stein and Leventhal, more extensively recognized syndrome. 1965 was the year in which a few patients, I think 8 or 10 patients, they had amenorrhea. They came in, wage resection was introduced by the same two persons, Stein and Leventhal, and they had resumption of menstruation, and they had a few pregnancies as well. And from that time onwards, where the RIA and your imaging technology gradually improved this technique or changed the protocol, put a picture of this technique into a subject where great interest came in, both of the clinician as well as endocrinologists. We need to define and changing concept of definition. 1960 to 1980, volumes of publications indicating multiple etiologies and heterogeneous clinical presentation. 1980, real interest came in because defining the syndrome increased because USC and RIA were discovered by that time. And 1967, I think Ian Donald described the EU imaging, and RIA was developed by some other endocrinologists, and they'll come to that RIA later on. Hyperandrogenicity, USG, hyperandrogenicity and hyperinsulinemia as background etiology become more clear. So these are the two endocrinopathies which are responsible, possibly, which are still possibly and I will say why possibly, and precise ovarian morphology, that the areas of the multiple cysts, why multiple cysts, why so much of sclerosis. So these things came to be known or became more clear in subsequent years. Now, changing concept and definition, people realized that there should be a definite definition of PCO. 1991, NIH defined PCOs as follows: chronic oligomenorrhea or oligoovulation, clinical or biochemical evidence of hyperandrogenism is present. That morphological changes in the ovary of peripheral multiple may not be present. The most important criteria of PCO amongst these three: oligoovulation, biochemical or clinical evidence of hyperandrogenism, and morphological changes in the ovary. So that became quite clear from 1991. But again, trouble started in 2003. NIH definition was modified by Rotterdam criteria in 2003. Well, two of the three are enough. Well, that created some confusion because without hyperandrogenism, how can a PCO occur was the question of most of the clinicians, because androgenism was the main pathological background of all the clinical manifestation of PCO, and how is that? I will come to later on. 2009, so Androgen Excess Society was there. So this Androgen Excess Society definition remodified Rotterdam criteria and included, no, there must be a hyperandrogenism, otherwise you can't call it a PCO, you can't call it a syndrome, because if it is a syndrome, it must be having a far-reaching consequence, and PCO has a far-reaching consequence. Well, the hyperandrogenism, diabetes, hypertension, and these clotting, thrombophilic and metabolic syndrome. So there are two syndromes which are invariable in a long-standing case of PCO at the elderly age. So if these long-term deficiencies are there, you can't call it only a disease. You have to call it a syndrome. And that was the debate. Anyway, the debate is still continuing, but we now believe further modification by NIH more cumbersome. So now we only believe that there must be hyperandrogenism. Now the current consensus believes basic cause of infertility in PCO is anovulation. And how? Through hyperandrogenism. That is the general consensus. If somebody may not believe it, they still believe in that Rotterdam criteria, but Rotterdam criteria has been modified gradually. Now, causes of that is very peculiar. So, causes of hyperandrogenism PCO. Well, these are the basic causes of hyperandrogenism in PCO. The basic cause, this is one of the Spanish endocrinology, Lebanese, something like that. And she said that, no, the basic cause is in the center, that is in the hypothalamus. And there is a pulsatile body in the hypothalamus, which is known as LH generator or GnRH generator, GnRH pulse generator. But because GnRH, gonadotropin releasing hormone pulse generator, is more LH favoring than FSH favoring, so it is commonly known as LH pulse generator. So plus minus and associated with that, this is the basic cause, which in majority of cases of PCO is the inborn, is a genetic disorder which starts right from birth and it is inherited. So we get the clusters of family or the members of the same family may have PCO. So that gene is there. There is the gonadotropin. This is nothing but your gonadotropin molecule. It's endocrine disorder. So these endocrine molecules accumulate and produce a strong pulse generator, LH pulse generator, which is more stronger in both activity and both. So, and in addition to this, may be associated with additional factors of hyperandrogenicity, and these are hypothyroidism, hyperprolactinemia. And if you remember your PCO cases, well, somebody will respond more favorable by adding L-toxin. Some person will respond more favorable by adding bromocriptine. So these are the associated causes. And how do they help in aggravating hyperandrogenism in cases of PCO? I'll come one by one. Hypothyroidism, hyperprolactinemia, hyperinsulinemia, and hyperadrenalism. Now, first of all, let us go to hyperactive LH pulse generator. They are hyperactive in both ways, both in frequency as well as in amplitude, meaning they are by more thicker androgen. But FSH is not absent, which is just diminished. And because of hyperactivity of LH, you get more androgen, will lead to central obesity. And that is the link with central obesity. And what is central obesity? I'll come to in a minute. And on the other side, because FSH is not absent, the follicular recruitment goes on, and the follicles grow to some extent up to semi-mature, and they do not mature, and therefore they do not ovulate. So this semi-mature follicle will just give rise to polycystic ovary. And androgen excess would lead to hyperinsulinemia, and will show the left side how hyperinsulinemia leads to obesity, leads to hyperinsulinemia.
If we click on the arrow on the screen, it will move next. On the left-hand side of the screen, we have arrows.
Yeah. So, yes, on one side, the hyperinsulinemia will cause obesity, and halfway mature follicle will lead to the morphological structure of polycystic ovary. The follicles will become atretic. They will act to the bulk of the connective tissue, and the ovaries will become not only big, but polycystic as well. Huh? Yes. So they will lead to central obesity, and central obesity means there are 4 areas where fat accumulates in the case of adolescent PCO. One is the peripheral fat, the second was peripheral abdominal fat, omental fat, mesenteric fat, and perigeneal fat. So what they will do, this visceral fat or central fat, they will generate cytokine. Cytokine will cause insulin resistance, and insulin resistance will cause hyperinsulinemia. So more susceptible to lipolysis on the other side, and free fatty acid will be there in the portal circulation, and this free fatty acid produces LDL, decreased insulin sensitivity. So this central obesity, as a consequence of hyperandrogenicity, will cause central obesity and insulin resistance. That is the mechanism in which insulin resistance is also associated with hyperandrogenism. I repeat again, these are 2 basic hormones on which the whole pathogenesis or etiopathogenesis of PCO will depend. Now the next, this LH pulse generator is superadded with some other endocrinopathies, and the 4 or 5 endocrinopathies. I will describe one of them one by one, and I'll then describe the association amongst these peripheral endocrinopathies with the genesis of PCO. Now, in hypothyroidism, all of you know, there is this sex hormone binding globulin. The sex hormone binding globulin are the carriers of 2 sex steroid hormones, and one is the androgen, the other one is the estrogen. So less sex hormone binding globulin in case of hypothyroidism will produce more peripheral androgen. Androgen becomes free, free androgen becomes more, and that will lead to hyperandrogenicity. Now, hyperprolactinemia also, prolactin has got 5 areas of action in the body. One is the pituitary, less GnR, gonadotropin, and the second one is the mammary gland. The third one is the adrenal cortex. Zona reticulosa is affected by hypothyroidism in case of hypothyroidism, and more androgen from zona reticulosa. Then the ovarian Graafian follicle, you can see the Graafian follicle, and lastly, endometrium is also affected. The action targets of this prolactin, also endometrium, to the luteal phase defect. So these are 5 areas. So in hyperprolactinemia, there may be androgen excess, and they will add to the density or intensity of hyperandrogenemia in case of PCO. Hyperinsulinemia is the last part, not the least one, and it works in 2 ways, through pituitary and through the liver. Through pituitary, acts as co-gonadotropin, stimulates more LH secretion through hyperactive LH fast generator more thecal androgen from the thecal androgen from the ovary, and suppresses hepatic synthesis of SHBG. When it suppresses, there is more androgen. SHBG, sex hormone binding property, and through liver also suppresses hepatic production of IVF BP1. That is, IVF is elevated, and when IVF is elevated, IVF1 and insulin are chemically and structurally similar. And if IVF1 through insulin-like action on the thicker cell will just produce more androgen. So there are the various ways by which your hyperandrogenicity in PCO is increased, and that produces all the pathological changes or pathophysiological changes in case of patient. And lastly, hyperadrenalism. Adrenal itself, I mean, in case of this pregnancy, there is in case of hyperadrenal is also stimulated because there is increased activity of the hyperactive adrenal stimulates adrenal enzyme increasing cytochrome P50, and this cytochrome is a bifunctional enzyme. It can stimulate the steroid, it can stimulate the protein hormone. The steroid hormone it is stimulating, and that is the reason why androgen is increasing, and the protein hormone stimulating. That is why the insulin is increasing. So these are bifact. So this is the whole summary of the reason or cause of hyperandrogenicity or background pathology, background etiology of the genesis of PCO. That is one is the hyperactive BNRH fast generator in hypothalamus with or without insulin excess, hypothyroid, hyperprolactinemia, hyperadrenalism. That causes number one, that is the hyperandrogenism. This hyperandrogenism then is converted into peripheral fat into your insulin. So hyperandrogenism is converted into estrogen, and this is estrone, and this is the catechol estrogen in the hypothalamus, and androgenized intra-ovarian inside the ovarian follicle, and that converts the estrogenized ovarian follicular environment into androgenized ovarian and produces more estrogen. So these three will just collect more estrogen in the body, but it is the estrogen. I mean, you remember we have the fluctuating estrogen which will cause the LH surge. It is not the static estrogen. So these three are static estrogen, and absence of fluctuating estrogen will cause no LH surge, and no LH surge means anovulation. So on this side, this is the background of anovulation of PCO, and there the androgen no sites at lead to site atresia, and that will lead to deposition of the connective tissue in the ovary, and that will lead to half mature follicles within the ovary, and therefore this is the morphological changes, etiology of morphological changes in the ovary, and this is the etiology of anovulation and non-ovulation. Static instead of fluctuating estrogen. Static estrogen will never cause ovulation, and it will cause the static estrogen anovulation. On one side, anovulation, on the other side, morphological. So this is about the pathogenesis or changing views on the etiology and etiological changes in the polycystic ovary. Now we have considered that all PCOs are not same. Somebody will respond very favorably to clomiphene or letrozole. Somebody will not respond to clomiphene and letrozole. And as you will see from the following slides, that all patients do not come with the same presentation. The group A, one group that is apparently normoestrogenic and normoandrogenic. So they must be hyperestrogenic, they must be hyperandrogenic, and they must be hyperinsulinemic. These are the three basic changes in the background of PCO. And this group will come, if you remember your clinical cases, non-heart-sweet, non-obese, no history of genetic background of insulin resistance, only delayed 35 days, 45 days menstrual cycle, a little bit obese, a little bit heart-sweet, no acne, and this is one group who are having menstruation but delayed oligomenorrhea. So ovaries are normally size, enlarged but no thecal hyperplasia. They are typical clomiphene sensitive. This group of patients, clinically will say, this group of typical clomiphene sensitive or letrozole sensitive, and you need not go to further for your ovarian drilling or some big surgery or some big treatment for them. Now, second group, the other group of patients that you have seen, must have seen in your clinic, mildly androgenized with hirsutism, mild obesity, oligomenorrhea, and ovulation. Ovaries are enlarged, stromal hyperplasia, peripheral cyst. They may still respond to clomipene citrate, but better option is to combine CC with metformin or inositol or other adjuncts like gonadotropin. They may require gonadotropin, but very rarely, and they only respond to aromatase inhibitor or with inositol. The third group, worst group, which are very dangerous sometimes, and these groups is typical obese and stocky subject with family history of, so clinically you can differentiate this PCO patient at the outpatient department and decide the type of treatment that they will best respond to. And this is the typical obese and stocky subject with family history of diabetes or PCO, oligomenorrhea or secondary amenorrhea, may have Heron syndrome, ovaries are polycystic, and there will be stromal hyperplasia. They are ideal candidate for insulin sensitizing agent like metformin with clomipene citrate or gonadotropin, ISA insulin sensitizing agent, ovarian drilling. And if they're living far away from your treatment place from the town, when you're living in the villages, it is better to do ovarian drilling than to give them gonadotropin because they'll be out of reach, out of monitoring area, monitoring zone. And therefore, I always do ovarian drilling and then give insulin sensitizing agent and your induction, that is the ovulation induction. Gonadotropin, ISA or ovarian drilling, down regulation, but better to do. There is a down regulation followed by ISA or followed by your follicular aspiration and IVF. So this is the picture of your grade 3. There is a type 3, that is the Heron syndrome, and all those who are familiar. And so the practical approach to management of infertility. Apart from calorie restriction, weight reduction, and lifestyle modification, management protocol will include induction of ovulation, ovarian drilling, IVF, IVM, collection of immature follicles and oocytes, freezing, in vitro growth, and in vitro maturation, and finally IVF. So this is the steps of management in case of all types of your polycystic ovary. Now, induction of ovulation as practiced at IVF, approach to induction protocol step by step, primarily based on clinical presentation of the patient, which in turn will depend on severity of the syndrome. As we have said, already described the severity, and accordingly we have classified them into 3 groups, group A, group B, group C. And drugs used for induction of ovulation, primary drugs, clomipene citrate, gonadotropin, aromatase inhibitor, secondary drugs, insulin sensitizing agent, metformin, inositol, dexamethasone, L-toxin, bromocriptine, etc. Now, drugs and protocols, how are the actual protocols? Drugs and protocols of induction and ovulation, we have 5 steps, one by one after the other, and one about the step 1, step 2, step 3, step 4, and step 5. And I will describe them, and if you like, you can take it up. Will depend on the severity of the disease already classified. And this is the first step. Step 1 protocol for group A and B. PCOS patients are described stepwise as below. Either you start with clomipene or letrozole 2.5 twice daily from day 3 to day 7. 1 ampoule of gonadotropin. Why you are giving 1 ampoule of gonadotropin, all of you know, to increase the follicular recruitment in the cohort, and that will may increase the pregnancy rate. Oral, we give the luteal support. We give the luteal support only because if they do not get pregnant, they will remain amenorrheic. And then they have to test the urine. They have to go for test the urine, and then again start the period menstruation, and then start the next step, stimulation. Without doing that, if they do not get pregnant, well, they will menstruate, and you can start the second stimulation protocol. And here we are starting clomipene citrate or letrozole from day 3 to day 7, and 1 ampoule of gonadotropin, because day 5 is the day on which the dominant follicle will form. Before the dominant follicle forms, well, we can recruit 1 or 2 more follicles in the cohort so that a chance of fertilization of 1 or 2 eggs will remain. And we do not monitor here because monitoring will take a long time for the patient to come to the clinic, wait for the folliculometry to be done. There is a wastage of time. That is the reason why in the A group, that is in the very early group, we do not waste time for the patient, waste time for the clinic as well. And after that, well, from day 16 to day 25, that is the time when we give a luteal support. If she is not pregnant, she will bleed. She will bleed at the end of your luteal support. Well, this is if he does not get pregnant with that protocol, then we go for the second step. In the second step, nothing difference. The only difference is we give 2 ampoules of gonadotropin into the ampoule group B, group B1 at the later stage. And after that second ampoule, then again, but they demand your monitoring, folliculometry. And after folliculometry, on the day on which the dominant follicle reaches the highest size, 18 millimeter, 17 millimeter, we give 1 ampoule of your HCG. And after that, either they end up with PI, by timed intercourse, or with IUI. And there's a definite type of, a positive or aggressive type of stimulation. Only 2 or 3 ampoules, not more than that. And if they do not respond, then you go for the third type of protocol. And that is third type of protocol. And this is only for a midway between the group B and group C. And here we have got the 2 alternative protocols, some more ampoules of gonadotropin with the same basic clomiphene and letrozole, day 3 to day 7. And this is which we call interrupted protocol. Alternate days gonadotropin from day 3, day 7, day 5, day 7, day 9, till the follicular mean follicular diameter comes to about 17, and they will always end in IVF. And if they still, and the other one is sequential, that is at the end of the clomiphene, we just start on with gonadotropin, and every day till the mid follicular diameter or least follicular diameter comes to 17. So one we call interrupted, the other one called sequential. So this is and the last one, it is still, and if you want not to do IVF at this moment, we want to switch it a few few months more, then we say the protocol of ovulation of induction followed by IY, which may be converted to IVF. That is a low cost. And when we come to the end, that is, we don't use clomiphene, we don't use the letrozole. We straightway start with gonadotropin, 2 ampoules, that is 150 IU, and from the very beginning. And ending on day 7 or day 8, we do ultrasound, we start estradiol. If they are unfavorable, then either we discard them or throw them out, or we have to go for a positive approach. If the number of follicles is accepted, but less in number, we go for IUI, either increase or decrease, and that is the way. That is here, day 8, we do the estradiol or the ultrasonography. Too many follicles, we measure estradiol and USG. And if it is, we are going for too many follicles, IUI, IVF, and because we have to aspirate the follicle, and too less follicle, still we can go for IUI. So this is the usual protocol which we follow. And lastly, if everything is finished, then you have to go for IVF. Now, this is the type of protocol that we use in our institute, and we are not unhappy. We are quite happy about that. And this because we always give a luteal support for the idea that I have already said. Now, somebody may not accept, but we are getting good results. Anyway, so these are the management protocols based on the unfavorable endocrine environment. There are PCOs which do not come with only FSH 5, LH5, something like that. Some patient may come with LH 8 or 10 and FSH 3 or 4. Then we have to bring down the LH before they do respond to some extent. They bring down. So best compared to LH, OCP is followed by CC FSH. So they are bringing down the LH and then treat them with stimulation. Then high androgen, that is the differentiation, dexamethasone. If we believe that DHEA is not, DHEAS is a very important cause of PCO, or not very much associated, because adrenal cause is not very much believed as an etiology or basic background of PCO, or adrenal is not associated with PCO. But in some cases, 8%, I think adrenal may be associated. And there books have also written, we have also seen that dexamethasone works. And dexamethasone, not too many days, dexamethasone from day 1 to day 10, not more than that. After before fertilization, there is a 2.5 half tablet at midnight, and that will reduce the quantity of DHEAs. And this is dexamethasone plus CC, dexamethasone CC plus CPC. And hyperinsulinemia, of course, it can go in two ways. One is a pre-treatment reduction of insulin by metformin, and then you can go by FSH, and sometimes pre-treatment with anti-androgens like spironolactone, that is aldactone, and this may help, but pre-treatment or simultaneously with induction of ovulation, you can do that. Or metformin or inositol, yes, inositol. And adjunct, no, not very commonly, there's a thyroxine, dexamethasone, all of this. So these are the abnormal, unfavorable situation when you have to give induction, but at the same time, the endocrine situation must be brought to favorable level, then you can expect very good result there. So that is all about the conclusion one. That is the PCOS women currently practiced ovulation induction strategy to be based on clinical presentation and severe. Not that in every case will letrozole or clomiphene will act. Where sometimes you have to add your gonadotropin as well. The previously practiced wedge resection has been reintroduced with modified terminology of laparoscopic ovarian dealing. Now, for infertility management, future thought, collection of immature oocyte IVM in the process of standardization. This will avoid considerable complications like OHS and multiple pregnancies. Thank you very much. I made it very short, and it's only for the general practitioner and practicing gynecologist or those who are very much interested in reproductive medicine, where it is only for them, basic thing, but it is our thought. We have modified the protocols of induction in that way, modified and rather according to the clinical presentation of the patient and the clinical type of PCO that you are dealing with. Thank you very much. Any question? Yes, questions must be there.
Thank you so much, sir. I think once again, it's an honor. It's an unprecedented honor, Dr. Pratibha ma'am. I'm Krishna Surendran, sir, from Kanyakumari. I'm Dr. Indra Surendran's, the late Dr. Indra Surendran's daughter, and I was your student. And I can still see that the way you present the things, you've seen it all, and the way you formulate the way you say it comes from a lot of experience. So I think there is so much that I learned today, and it's an honor to be chairing a session in which you're talking, sir. So with the greatest of thanks, and I can see one thing I think I wanted to tell everybody. One thing I think right after my embryology, when I went and visited sir, I went to sir's. My mother sent me there for a short spell. Sir said, if something works, don't really bother changing it. And I think that's something that I've practiced in 30 years of practice for me. So it's a big honor, sir. And I can still see the way you think is so different from the rest of us. Thank you so much.
Thank you. Thank you.
Any questions?
Thank you. Thank you so much, sir. Your talk was so informative, so explicit, and extensively covered all aspects of PCOS and infertility for us. Beginning from the etiopathogenesis, the clinical management aspects, and so many practical take-home points for us. Sir, it was such an honor not only hear about your academic aspects, but also your personal experience as a researcher, an academician, and your personal equation with Dr. Mukhopadhyay, sir. It has been a real privilege to hear you today, sir. And we all are very grateful for your time that you gave to us in this COVID era. And all pray for your long health. And I now request Dr. Bhaskar sir also to say a few words and conclude this session, this wonderful session today.
Diksha, there is one question.
Sir would always have the last word. So, sir, there is one question on the role of myoinositols in PCOS.
Role of myoinositol. A role of myoinositol is to reduce the level of insulin. That's the only thing, and without much complication. And that is a change of we were using this myoinositol and the other one, is between the two, I think the both are same in their practical application. Yes. Yes, Kamini, you want to suggest something? Kamini, myself, oh God, for a long, long time. She was I still remember in Bangalore.
Yes.
Yes, there's a meeting when Kamini came to reproductive medicine. And Sulochana was the girl who was commenting on Kamini's entry. Now, she said to Kamini, still I remember the word that she used, Kamini, you are just riding on a tiger's back. And when you are on the tiger's back, you are in trouble. Neither you can come down, nor you can walk. So entering into an IVF arena in the professional life is to ride on a tiger's back. So when you enter, neither you come down. If you come down, tiger will eat you. And if you go on, you don't know how long to go on. And so I still remember that's the Sulochana Gunushila. Yes, still I remember those days. And
yes.
Kamini was liked by our Devolda, Dargustu.
Sir, question is, sir, letrozole, which is preferred, letrozole 2.5 milligram BD or 5 milligram OD, which is preferable? Letrozole.
No, it is not for any reason, but from the very younger days, I've been using 2.5 milligram. When letrozole was not liked by anybody, I think I still remember, I was harassed by all my colleagues, not only all my colleagues, even by IC, even by Indian Medical Council. Yes, so many questions came to me. So many times I was brought to the drug controller's office. Why are you using? Everybody says it produces congenital malformation. So I collected all the papers. At that time, 26 or 27 papers were published. I used based on the information gathered from very good persons. At that time, this yes, Kasper Mitwadi. So they used to publish paper. Only those two persons from Canada. So they used to publish paper. Based on their papers, I used to comment on stuff. So from that point of view, I think 2.5, this is my habit. It's not that I have not compared them myself, but looking at the others' view also, or others' experience also, I think there is no difference.
Sir, second question, why we have so many PCO patients?
How?
Why we have so many PCOS patients?
We have. Now, this is our lifestyle, modern day, common day lifestyle. I mean, I say one child family is the commonest cause. One child family is the commonest cause of PCO, and there's a girl family. Because the mother is taking the child to the school, and father is going with the tiffin, and somebody else is going to be there. And then she goes to a tutor, private tutor, no time to go to the ground or have a physical exercise. And all these foods, there is the fatty foods, the high calorie foods, all these are taken by today are not very congenial for a girl to go without obesity. The BMI is high. You can see most of the adolescent girls nowadays, they are obese, overweight. So that is one of the very important reasons for more PCOS nowadays.
Sir.
This is a lifestyle change, I see. That's a social change, a personal life change, and the way of living change, and the type of diet that you will have. Nowadays, the age of menarche, in our younger days, we used to know Eskimos have menarche at the age of 23. But now we know whether Eskimo or an African or a Southeast Asian, well, the age of menarche is coming down. It is only because of nutrition. Balanced nutrition is good, but unbalanced nutrition is not good. So that is one of the reasons.
Sir, today they are talking about fetal origin of adult disease. So they're looking at even the culture fluid that is used for IVF and the fact that these kind of epigenetic disorders play an important role in the originating PCOS in these babies that are born through IVF. Your views on that, sir?
Huh?
Your views on that?
On what? The diet that you are taking?
Yes, because even of the culture fluid that is being used, the epigenetic problems that is being faced by these, that itself, it triggers off PCOS in the babies that are born through IVF?
I think both are the causes of a little bit high BMI. Both are the epigenetic. You can't ignore it, and that is that. Apart from the standard of diet that you are taking, that is an additional that can be avoided. But epigenetics you can't avoid. From 1971, if I remember correctly, these epigenetics has changed. And if you remember, there was but induced famine in India. Induced famine means somehow or other the rice was not available, the fish was not available, everything. And it was there's a small research on that done by an Indian student living in Norway. And he told that it is a mixture of, at that time, Japanese rice was mixed with Indian rice to make a super growth of rice. At that time, rice becomes so much available that it had to be thrown in the street. And from that time on, the problem of diabetes, the problem of high BMI, the problem of cancer breast in India went up. And it is said it may be a epigenetic change and brought out by, what is that called? That is, you are just mixing up two genes or two seeds and making a seed, and that
hybrid.
That is one of the causes.
Just a second. Explain about dexamethasone dose in PCOS. Dose of dexamethasone.
Dexamethasone, 2.5, half, 0.25, no, 2.5, half of that.
2.5 at 12 at night.
Yeah, that is for 10 days, not more than that.
Just 10 days.
That's it.
Thank you, sir. I think we should end it. Thank you very much, as usual. Mesmerizing, spellbinding, and thank you for being there and for so long. Thank you, sir. I hand it over back to Priyankur.
Priyankur was a good history about Priyankur's birth. Priyankur's father, 1 minute. Priyankur's father was my house surgeon. Yes, I have seen him born, and I was involved in his birth in some way or other. I think
you were primarily involved in my birth, sir, not somewhere or the other, sir. You were totally involved.
Fibroid, and I did a myomectomy, and after that he was born. There was some delay. I mean, not that a huge delay, but there was some delay. I did not bring him out, but somebody else did. But I did the initial job. I did a myomectomy, and then she.
Thank you so much.
I'm so happy. This Priyankur has become so great, so big. I'm so happy the way in which you are speaking. I bless you, Priyankur. Long life.
Thank you so much, sir. Means a lot, sir, when it comes from you. Thank you so much.
Your family.
Yes. Your product is doing well, sir.
Yes.
Yeah. You can call that a dividend, yaar.
Yeah.
So thank you so much, everyone. And we wrap up this session, which has been really wonderful by B.N. Chakrabarti, sir. And we move on to the most, awaited. We have this session's viewer question round. And in this round, we'll be declaring 3 winners, each of whom will get a certificate which has been signed by B.N. Chakrabarti, sir. And we'll be getting a copy of the Clinics of Reproductive Medicine and ART, which have been authored by sir. And so we'll be declaring 3 winners, and they'll be declared in the next episode of the KU series. So coming to the viewers' choice question of this series. Yeah, and so each winner will be getting the volume 1, 2, and 3 of the Clinics in ART and Reproductive Medicine. And we move on to the question. Can I have the question on the screen, please? Yeah, so the viewers' quiz question for this episode is, which of the following is the greatest single cause of infertility affecting more than or equal to 35% of the couples? A, abnormal cervical mucus, B, ovulatory dysfunction or decreased ovarian reserve, C, sperm disorders, and D is tubal dysfunction or pelvic adhesions. So seeing a lot of response, and this has been one part of a very innovative initiative by Pratibha Singh ma'am, which has been really appreciated. And yes, the poll is closed now. We've received 37 votes, and we'll be the answers and the prizes and the winners will be shared in the next round, in the next episode. So now we move on to the most awaited and exciting, the debate part of today. And for this debate, I invite the chairpersons now. The first chairperson is Dr. Radha Madhvi ma'am. Ma'am is the founder, president of Tiruvannamalai Obs and Gynae Society and the director of Rajam Multispeciality Hospital and Institute of Paramedical Sciences. Welcome, ma'am. And she's a practicing gynecologist since 1994 and has conducted the Gestocon 2017 and 18. Our second chairperson is Dr. Parikshit Tang, sir. Sir is a joint treasurer of Foxy. He's a consultant in Ashwini Maternity and Surgical Hospital and Center for Endoscopy and ART Mumbai and a consultant Jupiter Hospital Thane. He's also been the past chairperson of Safe Motherhood Committee and is a managing committee member of Mumbai Obs and Gynae Society. Has received various awards, been a Kamini Rao Yuva orator as well. So I welcome my chairpersons for this debate session, and I invite Dr. Radha Malai ma'am to introduce our speakers for the debate session. The next session is a very exciting debate on fresh versus frozen embryo transfer, a topic which is very relevant today because of so many papers being published recently, and a topic which can really change how we practice IVF and infertility today. So ma'am, over to you to introduce our speakers.
Good evening, seniors and colleagues. Good evening, Dr. Sir, Kamini Rao ma'am. At the outset, I would like to thank Dr. Pratibha ma'am from Bagalpur OG Society for giving me this opportunity to introduce the young.
Yeah, ma'am. Hello.
I think we've lost audio.
Yeah. So Parikshit sir is here with us. So sir, can you please introduce the speakers for us?
I would like to introduce.
Okay. Yeah.
Good evening, everybody. I just lost contact. I would like to introduce Dr. Rohan Setkar, head of the unit Bloom IVF, DY Patil Medical College, second joint secretary of AMOGS, joint treasurer of MAGE, managing committee member of MSR MOGS, associate professor at DY Patil School of Medicine, Foxy Korean Shanti Yadav Award, Kumut Tamaskar and late Praveen Mehta awardee, AVOFOG Young Gynecologist awardee, Foxy Yuva Orator 2020, ISAR Yuva Orator 2019. Well, I would ask him to come on to the debate. Next, I would like to introduce Dr. Anuradha.
Yeah, can we have the slide? Dr. Aradhana Gupta.
Dr. Aradhana Gupta has a vast experience of 25 years in the field of reproductive medicine. He is currently heading Aradhana Test Tube Baby Center, Bhopal, as director and senior consultant IVF. She is visiting senior consultant IVF in various hospitals in Delhi NCR. Former center head Bloom Fertility Center, Fortis Escort, Faridabad. She is a fellow in reproductive medicine from Mumbai. She has provided training to more than 50 gynecologists under the Foxy accredited advanced infertility training courses in Aradhana IV Center by Bhopal and performs many public awareness programs. Notwithstanding her activity field agenda, she has contributed academically in various national international conferences and presented papers in all these conferences. I welcome both Dr. Rohan and Dr. Aradhana.
Thank you, ma'am.
Let the fireworks begin.
Thank you, ma'am. Aradhana, ma'am, do you want to go first or should I go first?
As you wish, Rohan.
Ma'am, please, why don't you start? I'll take
Okay, fine. I'll start. I'll start first. No issue. Ladies first, right? Can I share my screen?
Yes, ma'am.
My, can you see my screen?
Yeah, ma'am.
Yes, ma'am. Yes, ma'am.
So, should I start?
Yes, yes, definitely.
Yeah, very good evening to all my respected senior, Chakravarti sir, and esteemed judges, and Pratibha ma'am for giving me the golden opportunity to speak on this very important debate in current scenario. Um, India has started its journey in the field of IVF by producing first IVF baby with frozen embryo in guidance of India's pride, Dr. Subhash Mukherjee, and our highly experienced judges would agree with me with the fact that it's necessary to have cryopreservation unit to run a successful IVF program in current scenario, which itself goes in favor of increasing the need of FED cycles. So, as a result of improvement in ART and especially with the invent of vitrification technique and the performance of cryopreservation program, the practice of freezing oocyte or freezing good quality embryo by subsequent FET at a time that is more appropriate for reasons of OHSS prevention, medical issues, efficacy or desirability has increased dramatically in recent year. And in current COVID scenario, it's really important to freeze the embryo. This fact is reinforced by this study, which shows that within 9 years, this freeze-all policy has been taken by the clinician of United States from 20% to 50%. And why clinicians feel that this is important, because control over and hyperstimulation seems to act negatively on the endometrial receptivity, and that causes the discordant glandular and stromal development because of the supraphysiological estradiol levels. As well as there is one more factor, an earlier rise in progesterone in stimulated cycle and during the late follicular phase, which again has a negative impact over the implantation. To circumvent the detrimental effect of supraphysiological level of sex hormones on endometrial receptivity, and based on the significant improvement of freezing or thawing procedure, the idea of postponing embryo transfer in a subsequent non-stimulated cycle took hold. And what are the advantages with a frozen embryo transfer? These are the additional, advantages like the avoidance of OHSS, which is really important, as sir has already given a talk, and he is stressing upon that PCOS is increasing day by day. We all can see that 30 to 40% patients are there in our OPD. And to avoid this segmentation, IVF is a very important thing which we can go through to avoid OHSS. And elevated progesterone, as I already told you, as well as luteal phase defect in the fresh transfer because of the multiple corporal lutea, and during pickup we take the cumulus along with the granulosa cells. Patients and physician preference is another angle we can see. We can store surplus embryo, plus chances of multiple pregnancy can be avoided during the fresh cycle. We minimize the risk of multiple pregnancy, as well as we reduce the need for the repeated stimulation cycle, and thus we can reduce the financial burden also. Then pre-implantation genetic testing is the very important thing which has come up nowadays and suggests the frozen embryo transfer cycle. This is a very important study. Rohan would also quote the same study. And this is a meta-analysis which shows that there is a significant increase in the live birth rate with the elective frozen embryo transfer. Although this study also shows that in normal responder, there is no difference in live birth rate. And but it significantly lowers the risk of moderate to severe OHSS in elective frozen embryo transfer cycle. The risk of preeclampsia was increased with the elective frozen embryo transfer, which is the only thing which goes against this FET, which will be taken later, although very limited studies shows it, and it's not a very common complication. Then outcome of FET versus fresh embryo transfer in mother in unit, if you see that, then again, only one thing goes in against it, is the hypertensive disorder of pregnancy increases in FET cycle, which can be taken care with the if we go for the this natural cycle for the FET instead of hormone replacement therapy. And because the corpora lutea not only produce estrogen, progesterone, but is also release some other hormones like relaxin, which can be crucial for the cardiovascular adaptation of the women to pregnancy. And second is the large for gestation age babies. That is not a very difficult thing, because in developing country like India, small for gestation age baby are more problematic, and I don't think this is a negative factor. Then so we need more for the natural cycle for FET instead of the HRT to compensate this problem, pregnancy-induced hypertensive disorder. Maybe Rohan would mention delay in transfer will increase the stress and anxiety. But I would take it, I would think differently. If you counsel the patient beforehand, I mean, before taking for stimulation about the pros and cons of the frozen embryo transfer in her case, then patient is relaxed. And in fact, when patient comes for the frozen embryo transfer cycle, she is well versed with the procedure. The load of taking daily injection and the things are not been there. And the patient is quite comfortable with the staff and doctor, and she is less stressed during this transfer cycle, and that is why we get the better cooperation from with the patient, and also better results. Cost effectiveness is another thing which in developing country like India is really important thing, because freezing increases the cost and burden over the embryologist. But again, I would say this can be compared by the taking another stimulation cycle and OHS's treatment, multiple pregnancy and its complication. I think cost effectiveness is less if you take all these things into the picture. So in conclusion, this cryopreservation has already substantially changed the therapeutic landscape. And though we need more perspective randomized controlled trial and cost effectiveness studies, but certainly it's a need of the hour, especially in the current COVID scenario, where patient, they want IVF, but they don't want transfer. They want transfer after the vaccination, after the passing of this era, and there are some other factors like medical reason. If the cancer patient, you would like to freeze all the embryo, in adenomyosis we give this segmentation thing. And there are a lot of social reason also, when the patient, they want transfer later, but they want their embryo to be frozen or their oocyte to be frozen, so that the age factor will not come into the picture. So thank you very much. This is what I can say in the favor of frozen embryo transfer, but the things should be individualized. Yeah, this is really important. So, thank you.
Thank you, ma'am.
Good, good. Looking forward to what Rohan has to say.
So I'm going to be talking about fresh embryo transfer, and I think my opponent has made some good points regarding the positive parts of a frozen embryo transfer. So obviously, Devroy in 2011 talked about the segmentation protocol, and as Aradhana ma'am has said, that in a lot of cases where it is indicated, the segmentation protocol does play a major role in playing a part for the embryo transfer, and frozen does hold a place. But do you use frozen in each and every case? Is it really going to help? That's the question. So as you can see that in 2015, we can see that there was an accelerating trend towards elective cryopreservation of all embryos following IVF, with transfer of thawed embryos in the subsequent cycles. But there are some questions that are still unanswered. What's the evidence that FET approach leads to improved live birth rates and better perinatal outcomes? Are there no risks involved with vitrification? What are the cost effectiveness of this approach? And what is the role of elevated estradiol levels in the perinatal outcomes? And some of the miscellaneous questions. So I'm going to try and cover these topics when I'm talking about the fresh transfers. You can always see we have two parts, and I think both parts have their own pros and cons, and it's eventually what you decide. And I'm going to be talking about fresh transfers, so I'm going to be trying and proving Aradhana ma'am's points wrong, but at the same time you have to understand that she comes from a right place where it does have a position. So what's the evidence that frozen embryo transfer approach leads to improved live birth rates? So this paper, which was published in 2016, which said fresh versus frozen embryo transfers for patients with PCOS. Sir has just given a beautiful talk on PCOS, and you can see that PCO patients, which were associated with increased live birth rates when you went for a frozen transfer, it showed decreased OHSS rates and increased preeclampsia, as Aradhana ma'am also said. But now, does this mean that you go for frozen embryo transfer for every case? PCO is not the only case where we are doing transfers. There was this paper published in 2018 for ovulatory women, and they saw that there was no significant difference in the clinical pregnancy rate, ongoing pregnancy rate, or the live birth rates between either of the groups. There was a significant lowered risk of OHSS in the frozen embryo transfer group. But now with our sonographies, with the blood tests, with the E2 levels, which we're able to do, with the progesterone levels we can do on the day of the pickup and everything, we can, I think, take easy decisions on deciding what triggers to give and take a very controlled decision on whether to do a fresh transfer or not. So I think it should not be taken for granted that a frozen embryo transfer in an ovulatory woman has to be done. I think a place for fresh transfers is very important in this situation. In fact, Fertility Sterility in 2018 analyzed 83,000 cycles from the SART registry. They also saw that high responders, yes, PCOD did benefit from frozen embryo transfers, but normal responders and poor responders, they found higher clinical pregnancy rates and live birth rates in a fresh transfer compared to a frozen embryo transfer. So therefore, fresh transfer in your patients with normal responders and poor ovarian responders holds a very good position. And in fact, it may give you better results when you're doing these transfers. Again, this paper published in 2018 again said that the fresh transfer definitely had equally good rates or even better rates in patients who did not have PCO. This was a paper which was talking about freeze-all policy in poor responders. Now, poor responders, it saw that there was no differences in IVF outcomes when comparing fresh to elective frozen thawed embryo transfer. Why put the embryo through that stress of vitrification and thawing, and then it's going to really increase the cost and the time? So it's better that in these situations a fresh transfer would be better, and a frozen transfer may not be indicated unless your hormonal levels suggest otherwise. Now, there are some risks involved with vitrification as well. There's a chance of increased spindle abnormalities post-vitrification, which can lead to mosaicism and abnormal embryo development as well. Then there can be difference in the gene expression in the BAX gene apoptotic stress pathway, and it can worsen outcomes in frozen embryo transfers. Now, which has better perinatal outcomes? As Madam said, yes, hypertensive disorders are easy to manage maybe in the obstetric outcome. And it's said that Kirk Conrad, in fact, said that the absence of corpus luteum in the program cycles are common, basically lead to an increased risk of abnormal maternal cardiovascular adaptation. The main reason probably is that besides the estrogen and progesterone, there's relaxin, VEGF, angiogenic metabolites of estrogen, which are also there. And these are not replaced. And the program cycle therefore results in a, preeclampsia. So this was another meta-analysis which was published in 2018 where it said pregnancy-induced hypertension. There was an increased risk of pregnancy-induced hypertension, increased risk of PPH, and large for gestational age babies. Yes, I agree that PIH can be managed in your obstetric outcomes, but At the end of the day, as an obstetrician, we want to try and avoid the risk factor for every pregnant woman. And in cases where we can avoid these risks of PIH, why not? And go ahead for a fresh transfer where they can get the possible prevention of pregnancy-induced hypertension. Postpartum hemorrhage, I think it's a dreaded complication for every obstetrician, and that was another thing we'd like to avoid. Yes, in India, we do have small for gestational age babies, but large for gestational age babies also have their own due risk. There is increased morbidity, increased risk of NICU admissions that increase the cost to the patient as well. Now, what about the cost effectiveness? Yes, when we're talking about elective cryopreservation, of course, there is additional expenses with cryopreservation. Your embryologists are going to have extra workload. Then your patient has to again spend costing on endometrial priming, monitoring your patients again before a frozen embryo transfer. Currently, there's no real study which has measured the cost effectiveness between a fresh and frozen embryo transfer outside a publicly funded healthcare system. But as you can see that in our country, in like India, where cost is borne by the patient themselves, it's very important that we have to take these smaller points into consideration. As you can see that fresh embryo transfer, when you look at the cost effectiveness for normal responders and poor responders, may not be effective at all. Then again, for patients with poor quality embryos, patients who have undergone a mild ovarian stimulation, patients with advanced age and indication to a short time to pregnancy, frozen embryo transfer could not be feasible or may not be necessary at all. Now, there are some topics that, like, it's going to take an emotional toll that a couple will be wondering that it's taking more time to pregnancy. Yes, counseling, as you said, that is going to help make the patients prepared, but that also, we don't know the mental fragility of each and every patient. At this point, they are looking, we have couples, in fact, all of us have couples coming with infertility for a long standing time. They've come in for a treatment. Wouldn't it be better to give them a pregnancy immediately rather than making them wait for maybe 2 months or maybe even 3 months prior to their pregnancy rates? Then this was another paper published in 2016 talking about a fresh look at a freeze-all protocol. It said that the major advantage was the freeze-all strategy was mainly eliminating OHSS. This also said that other factors supported a move towards this approach in ART. It enhanced your cycle scheduling, improved organization of an IVF unit. Taken together, they are basically leading to a new era in modern ART. It also confirmed the clinical benefits of freeze-all through a well-designed clinical trials before we shifted. Basically, this was a paper published by Blochil and his team in Belgium, and they said that freeze-all would be the way to move forward. In 2019, he published another paper that should we perform fresh embryo transfers in ART. And he actually said that there's not enough data to support the use of elective FET in all patients. So its use needs to be tailored in individual patients and circumstances. So therefore, you can see that, as Aradhana ma'am also said, frozen does have certain cases where it can be used, but not in each and every case. Also, Aradhana ma'am said that in this COVID pandemic, that frozen embryo transfer could be a very good option. But again, multiple monitoring, them coming back to the hospital again and again for these, for the endometrial priming. Wouldn't it be better that after the pickup, they come immediately for the fresh transfer, do the transfer, and they don't have to come back to the hospital, reducing their exposure to the pandemic at all? So to conclude, in this era of precision and personalized medicine, one size does not fit all. Do we have enough evidence to jump a dramatic shift to freeze-all or to a frozen embryo transfer for every case? No. Is it too premature to consider frozen embryo transfer for all patients? Yes. And should we recommend frozen transfer for a subgroup of patients who would actually benefit till further evidence? Yes. So we do have indications where frozen transfer is required, but fresh transfer would be preferred in a lot of cases, especially in this pandemic where it's not required. Go ahead with a fresh transfer. Thank you so much for a patient hearing.
Thank you so much, both Dr. Rohan and Dr. Aradhna, who were really persuasive, and both of us had us believing that their way was the right way. So I leave it to Dr. Parikshit Tank sir to conclude this exciting debate session. And also we have a online poll going on as to how many of us support a fresh embryo transfer and how many are in favor of a frozen embryo transfer.
I saw
So,
the results.
yeah,
It wasn't in my
let's see
favor.
how the voting goes. So, Parikshit sir, please, I invite you to conclude this session.
Thank you. At the outset, of course, my thanks to the Bhagalpur Society and Dr. Pratibha for the invitation. And it's really a pleasure to listen to stalwarts like Dr. Chakravarti today and see all the wonderful people, Dr. Kamini Rao, Dr. Meg, Dr. Basir, Dr. Bakshi. Great. It was really wonderful, wonderful program. Now coming to the debate, I think Aradhna and Rohan have been very persuasive. And what I'm most happy about is that they spoke a lot about individualization. And I'm glad that in spite of, having to make a debate, they were not too entrenched into their positions. And they did acknowledge that there is a place for everything in this world. So yes, today we have the technology to do a lot of things, but that does not mean that we should overuse or abuse the technology. We have to use a particular method of reaching the goal of a pregnancy in the most rational and logical way. And I think a lot of this has been illustrated in both the speakers, in the content of what both the speakers have put forth. My congratulations to them for a good exposition on this always controversial, always tricky kind of a topic. So what I feel is that the bottom line is individualization. Look at what the patient profile is, what the couple wants to do, and what is feasible and safe to be done in that particular circumstances. So I'll conclude by saying that I'm really delighted to be a part of today's program, and my congratulations to Rohan and Aradhna, and I hand it back to you.
Thank you, sir. Thank you.
Yeah, thank you so much, sir. I think it was very aptly summarized that individualization is the way to go forward, and probably let's have the polling online as well so that we can see how our audience feels about the same and how many of us actually more in favor for a fresh embryo transfer and how many in favor of a frozen embryo transfer.
In the meanwhile, I'd just like to thank Pratibha ma'am for giving me this opportunity to be a part of this program. Thank you so much, ma'am, for inviting me. And it was quite daunting to speak about this topic in front of all the stalwarts who are present in this program. So I hope we, both ma'am and I did justice to our debate.
Thank you, Dr.
Thanks, everyone.
I seem to have convinced a few people to switch towards fresh transfer from the last poll, I feel.
Thanks, Rohan, for such a wonderful presentation.
Madam, thank you so much. It was so nice to see you after
even
a long time.
Even I am not a pro for the all frozen, transfer.
Actually, I think, ma'am,
it should be individualized. Obviously, we both of us are working in same unit,
exactly.
So we have the same. But I just wanted to speak against it, and I wanted to put, some of the facts in today's scenario.
Yeah.
So I think the poll is closed now, and we can see that it has been a close fight, but frozen embryo transfer, 59% people have supported that 19, and 41% for fresh embryo transfer.
I saw this poll at the start of the program. It was 25 to 75. Yeah. After my debate, it has switched to 59 to 41. So I'm going to take this as my...
So if we give you a chance to speak again, you might be 51-49.
No, I think both the speakers did a great job, and it was a very close call, and I think we can call it a tie at the end.
Yes.
Absolutely.
But Rohan, even sir and ma'am, they also, would like to go for frozen transfer. Except few cases, poor responder, we don't have good embryos or something like they can't be frozen. Otherwise, they prefer freezing. That's a good thing because we have very good
Thanks to both our speakers for a wonderful session. And now I invite Dr. Pratibha Singh ma'am to say the vote of thanks and close this really exciting, innovative session which has been there today. So Pratibha Singh ma'am, over to you ma'am. It was such a pleasure to be a part of this program where we could hear all these stalwarts and experts in the field of infertility and IVF.
So thank you, Dr. Diksha. So once again, I would like to thank my viewers for their gracious presence. And first of all, I would like to thank our chief guest, Dr. Kamini Rao ma'am, for accepting our invitation and making it possible, and also giving her valuable input. So thank you so much, ma'am. My sincere thanks goes to our guest of honor, Dr. Mandakini Make ma'am, for her glorious presence. And many, many thanks to Dr. Asha Bakshi ma'am for staying throughout. From the bottom of my heart, I would like to thank Dr. V.N. Chakravarti sir for his so informative and up-to-date talk. At this age also, he is so well versed with his recent advances in the field of infertility, which is really commendable. And I also want to, that this shows his dedication towards his profession. And it was a real visual treat to all of us. And so thank you so much, sir, for such wonderful talk. And my sincere thanks goes to our chairpersons and judges, Dr. Bhaskar Pal, Dr. Krishna Surendran, Dr. Parikshit Tang, Dr. Radha Madhvi for chairing and judging the session so effortlessly. And finally, my applause goes to our young, so charming and dynamic debaters, Dr. Aradhana Gupta and Dr. Rohan Palshetkar, for making the debate so informative and fruitful and enjoyable. And really, it was very good. Thank you so much.
Thank you, ma'am. Thank you, ma'am. We are honored.
Thank you for having
I
us.
Really honored.
Thank our convener, Dr. Priyankur Roy and Dr. Diksha Goswami for conducting the program so smoothly. And in the end, I just want to thank our academic partners, Shield Connect, for supporting us and providing this platform to enrich and update our knowledge, especially Ms. Dr. Prachi and Mr. Saurabh and Ms. Chandralekha. Thank you so much for your background and help, and it is really commendable.
Thank you, ma'am. Thank you so much.
So now we are again coming up with our next webinar soon, and this time it will be on 1st of May, that is Saturday, because of some unavoidable circumstances. But the time will be same, that is 6:30 p.m. onwards, on one more, yet another interesting topic in Obs and Gynae by yet another great teacher of teachers. And our quiz will be flashed on this Sunday, that is on 25th of April at 12:30 p.m. So till then, stay tuned. Goodbye and good night. Thank you so much.
Good night, ma'am. Good night.
Good night,
you.
everyone.
Thank you very much. Thank you all.
Thank you.
For this.
Thank you.